All right, I am gonna move that down. Hello, can everyone hear me okay? I am Alicia Tucker. Oh, there's my picture. So I'm going to be talking about the recommendations for IHBLT, as the acronym goes in the guidelines, Intensive Health, Behavior, and Lifestyle Treatment, which hopefully is going to be a kind of practical tool for people to think about in implementing this piece of the guidelines within their clinical practice. I work clinically at the Children's National Ideal Clinic with Dr. Vadia, as well as Dr. Mirza, who was unfortunately unable to be here today, but had a hand in getting the guidelines out to us. And in my previous life as a primary care pediatrician, I kind of straddled both of these worlds. So I think a lot about ways to counsel on this in the primary care setting, not just the tertiary care setting. So I'm gonna touch a little bit on the take-home messages from the clinical practice guidelines that are gonna be kind of recurring themes as we're talking about this, and again, thinking about how to discuss this topic within the primary care setting. And I think just like Dr. Essel really kind of eloquently explained, that we really want to make sure that we're checking our understanding, our biases, that we're communicating our understanding of obesity as a chronic disease with our patients and their families, that we understand that there are a massive amount of factors that go into a child's weight, the physiological impacts, social determinants of health, psychosocial factors, and also in recognizing that bias and stigma exist and do need to be balanced as we're having these discussions. Highlighting those points that Dr. Vadia brought up, there is no benefit to watchful waiting, right? When we think about clinically monitoring obesity and its comorbidities, that we don't see any benefit in terms of saying, well, let's see if we outgrow this, right? I think that's a lot of families' feelings, a lot of the social feelings that they get. Let's see what happens next year, right? That's oftentimes just following that same path year after year. We know that treating these lifestyle factors are also going to treat comorbidities at the same time, and that we do have evidence-based strategies. One of the things I really want to highlight, and I'm going to kind of revisit this throughout this discussion, is that discussing this topic, having structured supervised weight management in place decreases current and future eating disorder symptoms. Bringing this up in the office, and just like the medical student had discussed during the IAT project at GW, they wish that their doctor had talked to them more about this topic, right? And we recognize that people are out there thinking about this on their own, right? They're being influenced by society, by social media. Us bringing up their weight in the office in a sensitive way, in a way that we talk about as it impacts their health, can really actually support them and decrease their risk of disordered eating behaviors. So I'm going to say this case is not important. I learn clinically, I think clinically, and so having this framework is just kind of how I want to present some of these topics to you. It's kind of a hodgepodge of patients that I've seen over the years. Please don't worry so much about the details, but if you like them, they're there, and feel free to read through them. So for this example, as we're thinking through, I'd like to think about an 11-year-old female who is new to your practice, who comes in for their checkup. They're there with their mom. You kind of peek at the chart. We have a history of asthma, nothing else kind of significant that has been written down for you on their intake sheet. And you notice on their vital signs that they have an elevated BMI over the 99th percentile. So that brings us to our first question, BMI. Dr. Essel actually already talked a bit about this, so I'm not going to talk as much about kind of the specific utility or not. But I think that, again, as we're kind of revisiting and checking our thoughts and biases as we're kind of going through again what a clinical case might feel like in the office, how do we feel about the BMI? How do we feel about bringing it up to people? I do a lot of just kind of fast talking when I'm in with patients, and so I'll even say, I noticed our BMI is elevated. We know that our BMI is not a perfect tool, but it's a screening. It does make me want to maybe ask a few more questions. If that's okay with you, can we talk a little bit about maybe some things that have been going on with our eating habits, or maybe that have changed from last year, right? Everyone's going to say these things in their own style. But I will often preface it in saying that it is an imperfect tool, but it's a screening tool, and it does make me want to, investigate. Maybe we're going to check some labs, like Dr. Vadia talked about, if we're, over the age of 10 and have some of these other risk factors. So when we're in our exam room, right, our patient has class 1 obesity based on BMI, and I think that the first step is really asking if they have any concerns. Maybe they want to bring it up. Maybe something else eclipses that concern. Maybe they hand you one of those cards and we're not going to talk about weight. I do a lot of thinking before we even get into that intensive health behavior lifestyle counseling stage, because I think those are things that we are going to really pull in a lot of other multidisciplinary services and ancillary services. And our role as this patient's primary care pediatrician is to make sure that we do no harm and that we start this conversation off at the right foot. We know, just like Dr. Essel said, that if we have a really negative experience, that may impact their whole relationship with healthcare and weight management going forward. So starting that conversation right is going to be really important, avoiding those stigmatizing terms, mentioning it as a routine part of care. And it can be challenging, right? And like I said before, I will often say these things that I'm thinking to patients. We know that a lot of different things affect our body weight. We know that there's stigma out there in the world. We know that people and kids go to school, go to work, have different food environments. The developmental stage of the child is going to play a factor. I say that to parents, right? Just to let them know that I'm not coming at this from a place of judging you, that I understand all these factors go into the conversation that we're going to have. If you sort of check your bias and you feel like this is not a discussion that I can have right now, maybe I'm not in a place where I'm feeling comfortable discussing weight, then maybe we actually don't discuss weight specifically, right? We talk about eating habits, drinking habits, psychosocial factors. I think there's a lot of other ways to kind of get at it. In this case, the mom kind of comes out saying, well, she's always been big, right? We hear that, we hear some of those terms a lot, but we've noticed a lot more weight gain, right? Ignore all of this heavy text, but the important things there that jumps out are that, like most of the patients that I think you guys probably see, there are multiple contributors to obesity. There's biological factors, there's socioeconomic factors, there's behavioral factors. And so again, before we even get into the IHBLT section, we're thinking of what is going on with this particular patient, because IHBLT is going to look very different for every patient. Maybe for someone who is experiencing depression or disordered eating behaviors, that looks like a stronger mental health component. Maybe patients that are experiencing food insecurity, that really looks like addressing that issue first before we get into nutrition education, because if they don't have nutrition access, how can we do nutrition education? And again, kind of the do no harm factor. I would really argue whenever we're starting to have the discussion about weight and eating habits, that we recognize that eating disorders and obesity really have a bidirectional impact and should really be screened for in all patients where eating disorders and eating behaviors may be being discussed. There's a couple quick screeners that people can do in their office. The eating disorder screen for primary care, I think, is probably the most global to address sort of all disordered eating behaviors, and kind of gets it a quick screen with these 5 questions. In the Ideal Clinic, we often do, well, and for all our new patients, we do disordered eating screening, and if we have any red flags in that area, would administer something a little longer, such as the BED7, the binge eating disorder screener, which is, and both of these are available free online if you don't have them in your practices. So our patient is again, I think like a lot of patients that I would see in primary care, somewhere in that gray zone that we've answered yes to maybe one or two questions, that maybe we have some disordered eating behaviors, but we're not fitting kind of neatly into a specific category. They're kind of in that disordered eating NOS when we do our coding. And so we want to make sure that that's kind of rolled into our discussion too. So where do we go from there? We've identified some acute concerns. We've identified that mental health resources may be needed. We've identified that there's food insecurity. And so these are going to be components that I want you guys to think about addressing when we start to think about IHBLT and how that's going to look for all different patients, right? There's no one particular prescription. There's multiple touch points over time. So that brings us to kind of the meat of the discussion today. This is pulled directly from the clinical practice guidelines, IHBLT, intensive health, behavior, and lifestyle treatment. As Dr. Vaidya had introduced, the clinical practice guidelines were really built on a trove of data. And so that's where these recommendations come from. And I think that's, something to keep in mind when we think about things like this channel category, right? It's not necessarily saying that virtual doesn't work when we're talking about some programs that people may access to help with behavior change and lifestyle counseling, but it did not have enough data or the strongest data. So it's not something that really made it into the clinical practice guidelines. I think that the dosage is what can feel a little daunting for most people, which is why I wanted to kind of set the stage a little bit to really encourage you guys as pediatricians and primary care physicians, subspecialty physicians, that we may be kind of the driver of the bus, or really actually what I often say to my patients is I'm the GPS, you're the driver, and then we're going to have all these other people kind of along the way, because they're really going to be driving what they want to do. I'm going to be kind of the guidepost. But the dosage that we do see be most effective is multiple touch points over a longitudinal period of time. 26 contact hours seem to sort of be the magical number in terms of getting meaningful health outcomes. And again, that's a lot. And I don't think that anyone really expects people to be doing that individually on their own in the office. Maybe some of your offices have additional services, dietitians on staff, health educators, nurses or NPs that have a particular interest in this area or additional training in this area. And so it can look like a lot of different things in a lot of different settings, whether that's a healthcare setting or a community-based setting. But the main focus is that it's, skill building and behavior modification. Just like anything when we're talking about behavior modification, whether that's, counseling for anxiety and exposure therapy, smoking cessation, right? We know that this is a longitudinal process. So we're gonna kind of fast forward with this case, right? In this magical case that I created, they got into a psychologist right away. They've joined a basketball team. They're more active. Mom's finances have improved. All right, this is like everyone's experience, I'm sure. So unfortunately, though, our patient has continued to gain weight. She's feeling very frustrated. We've got all these other physiological factors going on that we learned about earlier that we're going to let them know we understand that there's a lot of other complex factors going on. The mom would like to learn a little bit more to make sure that her daughter doesn't fall back into those negative eating behaviors again. So that brings us to what we start to think about to facilitate these healthy behavior and lifestyle treatments. You guys can, read this. They're in the guidelines. I know it's a little crowded up on the slide, but I'm going to highlight a couple of what I see as really important points that as we're trying to guide our families to different programs or maybe build some of these programs within our practices, some of the things that I think are really important to think about. I'm going to pause a little bit on the family-based. That was really consistent across the evidence that went into the clinical practice guidelines. I think there is amazing work being done in schools, in nutrition education. We want to increase kids' flavor palettes, their own understanding of health and nutrition. but their lived experience, their lived environment is at home with their family or caretaker, and those are the areas that we really need to intervene. We really need the whole family unit to be involved, and that's where you're going to see the most impact. And I think that can be a particular challenge with adolescents, particularly when I talk to parents of adolescents who often feel like, well, it's what he's doing with his friends. I can't tell her what to do. And that is true to some extent for those of you that both treat and have teens, but they're still in that home-based environment. And so making sure that we're really incorporating that holistic family factor is going to really be the cornerstone of a lot of these successful programs. And then the other thing I want to pause on is aligned expectations. I think this is really, really critical. And I don't think this is something my colleagues necessarily touched on in terms of outcomes when we were discussing a little bit of sort of this physiology and treatment. I know Dr. Essel shared that very dramatic slide from The Biggest Loser. But what we see really with most lifestyle treatment is modest weight loss. And for a lot of us that do this work, that's great. A 5 to 10% weight loss of excess body fat can be massively impactful on health. It is shown to be, clinically beneficial to reduce the inflammation associated with NAFL. Even a 10% weight loss can be effective in reducing cerebral pressure for patients with idiopathic intracranial hypertension, right? These are small numbers, especially for patients with very severe degrees of obesity. And what we often find is sometimes when they're not seeing the results that they expect, right? They've seen a TikTok video where someone did this keto diet and lost 50 pounds, and you referred them to some program and they lost 5 pounds. Why do I want to keep doing that, right? So we want to really set those expectations up in the beginning and to align your expectations with the patient's expectations, because while we are really emphasizing the importance of health, and I continue to emphasize that, and I will often tell my patients, my goal for you is to reduce your A1C to this level. We're going to work on these nutrition changes, and I do expect that to help get you out of this prediabetes range. Maybe it'll help you lose weight, maybe it won't. That's not necessarily my goal, but what is your goal, right? They may have different goals for themselves. And it's not to say that either of those things are right or wrong. You just want to align your expectations with what your patients want, and to be, again, be that GPS, be that guide that's making sure that they understand really what is physiologically typical, right? They know that person in their family that's, had that degree of weight loss, that probably has that bias that Dr. Essel talked about because they've been able to do it so successfully, but that's not the case for everybody. So what can we do? So I'm going to transition a little bit to talking about what are some of these programs in our area. As I mentioned, I work with our Ideal Clinic at Children's National. We are really set up as a tertiary care model for patients with severe obesity and obesity-related comorbidities. That's not going to be the treatment level that everyone needs, and even for those that do, we know that we are a busy practice and that there are a lot more kids and teens that need treatment than we always have capacity for. And so we really want to work on building these partnerships with you guys and with our community programs. Hopefully I did this right. I'm not the most tech savvy. Feel free to see if this works. If you would like to link the QR code, this takes you to the AAP Institute for Healthy Weight website that has the links to these programs. It's not a huge amount of programs, but because these are things that the AAP wanted to have available and accessible across the country, they're sort of different models. Some of them are things that utilize partners that, again, tend to be available nationally, things like Parks and Recreation Services, things like YMCAs. Some of them are also modules that can be implemented both in the community setting and in the medical home setting. If these are anything that practices would like to build and incorporate, there's tools on how to do that as well. What might this look like? This is the YMCA program that utilizes the MEND program. If you kind of read the details, it gets very close to those 26 contact hours, or actually over that because it's 25 2-hour sessions. So we're getting close to our 52 hours, which is an even more magical number if you read the guidelines in terms of impactful changes in health outcomes. So When I Googled, we don't have a specific MEND program at our YMCA here. Maybe we can start one if there's anyone passionate about this or wants to kind of advocate in their local community. But what do we have? So I do want to give you guys some concrete things that we actually do have accessible in this area and within the communities. Most of these are built around DC, but I would say are also available in the sort of metro DMV area as well. The local YMCAs do offer a couple different programs, one for SNAP eligible residents and one that's accessible to everyone. Most YMCAs also do have registered dietitians on staff and offer that as an option. So if families don't want to travel to a hospital or a clinic, but have a local YMCA, they can actually often see a registered dietitian and get one-on-one nutrition counseling through that avenue. Other organizations like Common Threads, Martha's Table, Giant Foods actually has some pretty good nutrition classes. They have registered dietitians. Some of them were actually also doing kind of these healthy grocery store tours and cooking demonstrations that people could sign up for. And then for a more structured multidisciplinary program, there's certainly our Ideal Clinic, but there's also the HSC Healthy Habits at HSC and Bunker Hill that offers both virtual, and I do believe they're back in person. This may actually be a little outdated since it said virtual. It was previously in person and went virtual during COVID, but now I think they actually offer a hybrid. Children's National has general nutrition dietitian services as well. So maybe we have a patient, that has a mild dyslipidemia, something that feels like they do need more intensive nutrition counseling that may be either out of your scope or just out of your time eligibility, and want to get some more support, but they don't need kind of a full weight management program. There's options at really almost all the regional outpatient centers and different numbers, so feel free to take a screenshot of that as well. We have started a website, and I will say there's a big team of people. Dr. Essel and I have been working with a big team at Children's to get more resources together to disseminate out to the community. One of those is at this website, flipdc.org, and has a lot of good resources around healthy eating, as well as specific resources with links for clinicians. Some of these are meant to be a little more patient-facing, such as the produce directory. I have a very picky son, and I will actually sometimes make him sit down and pick what vegetable he will actually eat that week. So, some of these things can be things that we do with our own kids. But from the clinical side of it, we have links for physical activity resources in the area, as well as links for additional clinician resources with both patient handouts and some counseling tips on nutrition around specific conditions. And we will be disseminating more resources in a forthcoming email from the PHN with an additional toolkit incorporating both clinical algorithms, community-based resources, and a lot of the referral options through Children's National. So please keep an eye out for that email after the conference. And then just a couple other local resources to share for those that are interested. GW offers a culinary medicine program. This is more geared toward clinicians that want to build that kind of into their scope of practice. It can be for a host of healthcare professionals, not just MDs, and offers multiple modules for clinicians and other healthcare professionals that again want to kind of build this into their practice. So in kind of wrapping up from our case, right, many patients are going to use a combination of healthcare visits, community-based programming. Our patient, once they got into a stable place, was able to connect with a dietitian, and so they would have frequent dietitian visits, and then we, as their pediatrician, would see them monthly to again kind of serve as that guide. And your visits count too, right? You're sort of the care coordinator. I'm not not going to get into motivational interviewing. Again, this is just my little brain dump of thinking about how I would kind of walk through a primary care clinical encounter. You're going to have a great discussion on motivational interviewing a little bit later today. But I think those are really important tools. And again, you're the guide. You're going to help to figure out what's working and what's not working. And I think a lot of us probably have this similar experience maybe when we refer patients for physical therapy or for counseling with a psychologist, right? We're going to see them back and we're going to say, is this working? Is this not working? Do we, are we sort of stuck in a place where we need medication to actually make this piece of counseling effective? Are you maybe with a counseling partner that's not effective for you and we need to find a different program? So we're going to be using kind of some of these motivational interview techniques to assess where our patients are in their journey and to see if they're on the right track, and if not, see if we can kind of continue to guide them along the way. So we discussed this a lot earlier. I'm not going to harp on this because I think Dr. Essel did such a beautiful job of explaining why it's so important, but I just want to kind of re-emphasize this as I wrap up. We know that historically, physicians have been a leading cause of stigmatization for patients, and so we really want to shift that framework to say that it is something that we do feel like is important to their health and that we can discuss in a clinical setting, but that we need to be coming at it with that compassion and empathy and really having patients understand our understanding of the complex physiology, that we don't think they're lazy, that they're just not eating the right foods, right? That we recognize that this is something that is a healthcare condition just like anything else. So in summary, we're going to ask questions. We're going to start out by, again, asking patients where they are, if this is something we can discuss, if this is something they have concerns about. On the flip side, right, if we are losing weight, are we doing it in a healthful way, right? We don't want to just kind of see the number on the chart go down and give them a cheer and move on to another topic, right? We want to be recognizing again that this is a chronic relapsing condition, that it can be bidirectional toward disordered eating behaviors. And so we want to keep asking questions along the way. We're going to ask permission. We're going to avoid those stigmatizing terms. We're going to use our motivational interviewing techniques. We're going to focus on their behaviors, not their weight. We're going to focus on their health, not their appearance. And we're going to hopefully take some of these tools away from the conference today to have these programs in your back pocket so you feel supported as well, because I don't want anyone walking away thinking that they have to kind of do all of this alone. So thank you. I understand we have extra time for questions, so I maybe won't do questions at the moment, but I'll defer to my colleagues. Thanks for your attention.
I was going to first, thank you, Dr. Tucker. Are there any key questions just around clarification? We're going to have a little bit more extended Q&A session after the break about actually translating all these new knowledge and guidelines actually into practice. But if anyone has a quick question, we can do that now. It's like, can we get a mic? Okay. Just stand up and introduce yourself, because we're all one big family here. It's like we're getting you a mic.
And I would love to know if there's any hope of developing any of these wonderful resources in Spanish. We have a multicultural environment here in the DMV, and these are all fabulous, but we can't hand them off to our patients if they don't understand the language. Any hope about translations?
Yes, so for anything in particular, just any programs in general.
Because your website looks fabulous.
Thank you. That's very nice. Yes, so our website in particular, there actually is a ongoing project to get most of our resources translated into Spanish, and we do actually have the patient handouts translated into Spanish. In terms of more modules, we are actively working on that with some great medical students right now. I would also encourage, some of our other community partners, right? Mary's Center has some really great family-based interventions, and they, specifically work with a Latino population. And so they have a lot of group classes that are available. I know they were actually doing a lot of things with more early childhood feeding practices. So I can't think of other specific programs off the top of my head. The Latin American Youth Center is also a very good resource for families that need more nutrition education support in Spanish.
Nutrition program also has Spanish-speaking dietitians.
Oh, yes.
Which would make it great, in terms of cultural competence and helping these families figure out how to change their diet within their cultural context.
Yes. And I will say, I know at least one of our dietitians is fluent in Spanish. There might be more. No, just one. Okay. So we would like to get more. But one of our dietitians at Children's is fluent in Spanish as well, if you have the numbers for those general nutrition services.
We are going to do a broader Q&A session after the break. So I just want to, but if there are just specific things about what Dr. Tucker's put up there, we're going to get into actually the real world, and it's like we're in busy practice and trying to make all these connections. We're going to talk a bit about that after the break. But if there's specific things about what Alicia's just sort of put up there.
Find out if...
Introduce yourself.
I'm Regina George. I'm from Cockeysville, Maryland, a pediatrician. I just wanted to find out if you know what the role of health coaching would play, apart from dietitian, nutritionists, and all that, in obesity management.
Yeah, I would say that counts, right? So I think it depends what the topic is that they're discussing, but I think we have a lot of great health educators, health coaches, right? A lot of support staff that can, do a lot of great CME work around kind of nutrition, activities, CBT, motivational interviewing, and all of that counts kind of in your contact hours, right? The more touch points that we have, the more lasting behavior change we know we get.
All right. Thanks all for your, what?
Someone's waving.
Why don't we talk about that?
15 minutes, half an hour.
Thanks for your question. I'm just going to repeat it because we're recording, but the question was, in these busy practices, how long are these visits?
Yeah,
Typically
actually, I was going to suggest we have that conversation as part of the group discussion after the break, because that really is coming down to the meat and potatoes. Wait, this is an obesity conference. It's coming down. It's coming down to how we translate the salad and
you can eat meat and potatoes in moderation. No food is a bad food, Dr. Weissman.
So let's make that part of the conversation, because that's really what we want to get down to. It's one thing seeing guidelines on a screen. It's another thing actually trying to figure it out. But we are all in the same situation. We're in busy primary care practices. We're supposed to be doing all this work. We're supposed to be screening for behavioral health and mental health, now obesity, and it's not one or two kids. This is a lot of kids in our practice. That's what so we'll spend some of the time talking about that after the break.